on to the next scenario, case study scenario 2. Miss Eve, please and thank you.
What had the CPT and high CD10-CM codes reported? A. 15830, 15847, B. 15877, C. 15830, D. 15830, 12031. Preoperative diagnosis: funiculus diastasis rectal. Post-operative diagnosis: funiculus diastasis rectal. Procedure performed: abdominoplasty. Anesthesia general. Clinical notes: the patient has had multiple pregnancies, with diastasis recti occurring with the last pregnancy. She has had long-term problem with low back pain and constipation because of the diastasis recti to the point where child care and everyday activities are limited. Since having her last child, she has also developed a panniers causing significant chafing and irritation, which at times results in bleeding and infection. She's here today for the above procedure. She understood the potential risk and complications, including the risk of anesthesia, bleeding, infection, wound healing problem, unfavorable scarring, and potential need for secondary surgery. She wanted to proceed. She also understood the possibility of impaired circulation to the flaps and hematoma, seroma formation. Procedure in detail. The patient was placed on the operating table in supine position. General anesthesia was induced. The abdomen was prepped and draped in the usual sterile fashion and marked for abdominoplasty along the suprapubic natural skin crease. This caused 36 cm in total. The umbilicus was also marked and the area was infiltrated with 100 cc of 0.5% xylocaine with 1.200 epinephrine. After adrenaline effect, the incision was made. The flap was elevated to the umbilicus. The umbilicus was circumcised and dissected free with care taken to maintain a generous vascular stock. Dissection was then taken to the subcostal margin as it tampered superiorly and narrowed the exposure. Hemostasis was obtained by electroartery. This was still a lot of skin laxity, and it appeared that an ellipse of skin could be removed through the superior margin of the umbilicus. The flap was incised at the midline for greater exposure. She had significant diastasis recti, which was closed with interrupted mattress sutures of 0 ethibond, followed by a running suture of 0 ethibond. She was placed in semi-flex position, and the ellipse of skin was excised to the superior margin of the umbilicus in the midline. This gives an easy fit for the flap without undue tension. The 15 drains were placed through the Mons area and secured with 3-0 proline. The skin was then closed as scapula fascia with sutures of 2-0 PDS. The umbilical site was marked and a disc of skin was removed. The umbilicus was delivered and sutured with dermal sutures of 4-0 PDS and the skin with 5-0 fast absorbing plain gauze. Deep dermal repair was completed with reabsorbable staples, and the skin was closed with a subcuticular suture of 4-0 PDS. Sterile strips were applied over masticor and abdominal binder was placed. The patient was awakened, extubated, and transferred to the recovery room in satisfactory condition. There were no operative or anesthetic complications. Estimated blood loss was less than 30 cc. Holders, you have some minutes to answer this question. Your time starts now.
Okay, coders, great response in the chat. Okay, no audio. I've just started talking. Am I audible now? Okay, thank you. Thank you for letting me know. So, yeah, good try, good attempt in the chat, and good participation as well. So, Koda, we have in post-operative diagnosis two conditions. One is a panniculus and one is diastasis recti. And procedure performed abdominoplasty. Patient is suffering with diastasis recti. Patients having a low back pain, constipation because of the diastasis, developed pannus, significant chafing. Patient is on operating table. Umbilicus also marked. The area infiltrated with 100 cc of 0.5 percentage silocaine. Incision was made. The umbilicus dissection was carried out. Skin could be removed through superior margin of the umbilicus, and there was a closure with interrupted mattress sutures of zero. I think it's zero. Ethibond followed by running sutures of zero ethibond. So, yes. And another tip for you all coders, do not always go blindly by seeing the terminology which is used in this particular portion, the procedure performed. So even if they have mentioned like abdominoplasty is the only procedure performed, always go ahead and read what is in there in the procedure note as well, because sometimes the goal of the surgery will be one, and while the doctor performing the surgery, he might find out something else, and he will do maybe an additional procedure, or he might have to change the procedure. So always go and read the procedure note and make sure that uh, there is no additional surgery performed. So over here it was abdominoplasty, and actually there was two surgeries, two procedures performed. One is abdominoplasty and one is panniculectomy. So you can see the excess of the skin was excised, and there was also some closures which is performed over here, and I will explain you that with the help of the image as always. So this is what a panniculus looks like. The panniculus is an apron of skin and fat hanging from the abdomen below the waistline. So as you can see in the image, there are different stages of panniculus, like from stage 1 to stage 5, and stage 5 is definitely is the most severe. And this is an image of how it looks before surgery, where you can see there is an excess of skin that is hanging, and one after the surgery as well. So one of the treatment option, definitely surgical removal is the only way to get rid of the panniculus which does not respond to the diet or exercise. Okay, so that's what a procedure performed over here. There was a panniculus, or the removal of excess of skin. And now let's talk about the second condition, the diastasis recti. And there is another image representation of what a diastasis recti looks like. A diastasis recti is a common condition in pregnant and postpartum people, and it occurs when the rectus abdominis muscles, which is also known as six-pack ab muscle, separate during the pregnancy from being stretched. And this separation can make a person's belly stick out or bulge months or years postpartum. So that's where the six pack ab muscles will stretch and it will move away from each other. So, what is a treatment option? Diastasis recti surgery, which is similar to the tummy tuck, or abdominoplasty. It is also known as abdominoplasty since it involves surgically bringing back the separated muscles together. So you have seen like some sutures were also performed during the procedure, so they have brought back this muscle group as well. So that is the two procedures which is performed in our scenario. So we have highlighted the keywords, the documentation. Next we are going to inventory our procedure. So we have an abdominoplasty and panulectomy performed, and in the diagnosis inventory we have a panicles and diastasis recti as well. And patient also suffered from the low back pain, constipation, chafing, irritation also. So if you remember, coders, how to identify our first listed code, we can get it from the first listed code chart that is available in your MCG manual. And if you remember the guideline number 1, it states that for the signs and symptom may be listed first when no diagnosis is present, and also do not code the signs and symptoms when it is integral to the codable diagnosis. So we have a paniculus and diastasis recti, which is mentioned, which is a main diagnosis in the scenario. At that time, do we have to code the low back pain, constipation, chafing, irritation, etc.? Do we have to code them? No, right? No. Exactly. So we won't be coding because they are signs and symptoms, which is integral to the main diagnosis. So we will eliminate all those signs and symptoms, and we are only going to code for paniculus and diastasis recti. So with that said, let's move back to the coding portion, and let's have a look at option B, which is coding for 15877. That is for a suction assisted lipectomy of trunk. So we didn't had a suction assisted lipectomy, we had a surgical procedure, we had a surgical abdominoplasty and panulectomy performed. So option B is incorrect. Option D is coding for 15830, which is a good option. It is for excision of excessive skin and subcutaneous tissue, includes lipectomy, abdominal, infraumbilical panulectomy. Yes, a panulectomy was performed. An excision of skin and subcutaneous tissue was also performed, but option D is incorrect because it is also coding for 12031. And if you look at the parenthetical guideline, it says that do not report 15830 in conjunction with 12031. So that is the reason why option D is incorrect. Now let's look at option C and option A. So the major difference is that option A is coding for an additional CPT code of 15847, and 15830 is definitely for panulectomy, and 15847 is also coding for excision of skin. Subcutaneous tissue includes lipectomy, abdominoplasty, and it includes umbilical transposition and facial plication. So that is coding for our abdominoplasty, which is also present in the procedure inventory. So we have both the procedures covered over here, and option A is going to be the correct answer, and option C is only coding for a panulectomy. So most of you had few of you had a confusion between option A and C. So the key thing to follow here is to read the procedure note carefully as well. Be a little bit forensic. That would what I would say. And also, if you went by old school method by looking into the appendix, you can see that under the abdominoplasty itself, it states that you have to go and look for two codes. One is for 15830, and that is for panulectomy, and also 15847, which is for abdominoplasty as well. So that will also guide you to the procedure or to the correct answer. So how are you feeling, coders? So that was a good scenario and something which we learned from that scenario also. So great. Okay. So let's quickly move on to the scenario number 3. We have a lot to cover today. So Miss If, here's the scenario 3. Thank you.
What CPT and high CD10CM codes are reported? Preoperative diagnosis, right breast mass, lower outer quadrant. Postoperative diagnosis, right breast mass, lower outer quadrant. Procedure, right breast lumpectomy, anesthesia, a 1% lidocaine with epinephrine mixed with 1.1 with 0.5% marcaine along with IV sedation. Indications, the patient is a 23-year-old female who recently noticed a right breast mass, lower outer quadrant. This has outgrown somewhat in size, and we decided it should be excised. Findings at the time of operation, this appears to be a fibroadenoma procedure. The patient was first identified in the holding area, and the surgical site was reconfirmed and marked. Informed consent was obtained. She was then brought back to the operating room where she was placed on the operating room table in supine position. Both arms were placed comfortably out at approximately 85 degrees. All pressure points were well padded. A timeout was performed. The right breast was prepped and draped in the usual fashion. I anesthetized the area in question with a mixture noted above. This mass was at the areolar border at approximately the outer central to lower outer quadrants. I made a circumareolar incision on the outer aspect of the areola. This was carried down through skin, subcutaneous tissue, and a small amount of breast tissue. I was able to easily dissect down to the mass itself. Once I was there, I placed a figure of 8 2206 suture for traction. I carefully dissected this mass out from the surrounding tissue along with a margin of healthy breast tissue. Once it was removed from the feed, the traction suction was removed and the mass was sent in formalin to pathology. The wound was then inspected for hemostasis, which was achieved with electroartery. I then reapproximated the deep breast tissue with interrupted 3 to 0 victory Celsius and another 3 to 0 victory Celsius in the superficial breast tissue. The skin was then closed in a layered fashion using interrupted 4 to 0 monocrystal deep dermal sutures, followed by a running 4 to 0 monocrystal subcuticular suture. Benzene, Steristripes, and dry sterile prayer were applied. The patient tolerated the procedure well and was taken back to the short stay area in good conditions. Coders, you have some minutes to solve this scenario.
Okay, Chorus, I think you all smashed this scenario out of the park. That was great. Great question and great answers in the chat as well. Okay, so just give me a moment.
Okay, so we have a right breast mass of lower outer quadrant as our postoperative diagnosis in the scenario. Also, the procedure performed right breast lumpectomy. Patient was placed in a supine position. Anesthesia given, circumareolar incision on outer aspect of areola performed, carried down through the skin, subcutaneous, and a small amount of breast tissue. Carefully dissected the mask out from the surrounding tissue and closed in layered fashion. So that's all we have here. And procedure inventory, we have a breast lumpectomy, layered closure. We won't be coding for layered closure for this scenario because that is inclusive in the lumpectomy procedure. And diagnosis inventory, we have a right breast of lower outer quadrant. Now next, what we are going to do is that we are going to select the code that best matches our inventory list. So 19300 is coding for a mastectomy for gynecomastia. So did we had the patient here for a mastectomy procedure that was for gynecomastia? No, exactly no. We had a scenario where patient came for a right breast lumpectomy that is performed for a treatment of a right breast mass, and that was not a visit for a gynecomastia. So option B is incorrect. Option C, coding for 19303, now that is incorrect because it is coding for a mastectomy simple complete. So mastectomy means it's a complete removal of the breast, nipples, etc. So we didn't had a mastectomy performed. We only had a right breast lumpectomy performed. So that's a reason why option C is incorrect. And now between option A and option D, option D is coding for mastectomy partial, and you can see in the brackets as well they have mentioned the procedures that are performed. It includes a lumpectomy, tylectomy, quadrantectomy, segmentectomy. Now let's cross check with the procedure inventory. We had a lumpectomy performed here, and that's also included in 19301 code. So 19302 is incorrect because that is coding for a mastectomy partial along with axillary lymphadenectomy. So with this image, I will help you what one difference between 19301 and 19302 is, because there were a few answers which were coming up for 19302 as well. So you can see what happens in 19301. Let me just take out my pointer. Yes. In 19301, which is a mastectomy partial, which includes lumpectomy, you can see an incision was made and a lump was just removed from the breast, while in 19302 the incision was made and it is extended over the axillary areas as well. So the lump was also excised and the axillary nodes was also removed. That is, axillary lymphadenectomy was also performed in option A, which is 19302. So always you have to cross check with the procedure inventory and confirm which procedure was performed. So here an axillary lymphadenectomy was not performed, so which means option A is incorrect. The correct answer is going to be option D, 19301 RT and N63.1. So that is your correct answer, and coders, I hope the explanation helped. So let's move on to the next scenario. So if you have any questions, please place it on the chat, coders. So